Welcome to Variations 4, the respiratory unit. In this video, we're going to cover numbers 7 to number 10. The main topics are rebound hypotension, that comes with draining any bodily cavity too quickly, and a quick overview again of pulmonary embolism. So the first question asks about Rick here, and he's getting some fluid drain from his pleural cavity. He's got a chest tube in situ, obviously. Before we get into this, let's look at a picture, though, that we looked at before in Unit 1. So you probably remember this picture. And we talked about hydrostatic pressure in Unit 1 and how it can work in two ways. In the last video, we talked about CHF and how hydrostatic pressure can push fluid through the vessels into tissues. Well, now we have to talk about the other side of hydrostatic pressure, and that is what happens if you take an organ and drain it too quickly of its fluid. For example, common organs that we drain in healthcare are the bladder by way of catheterization. I personally haven't seen a whole lot of rebound hypotension from using catheters on patients who have a lot of cc's in their bladder, like over 1,000. But that doesn't mean it can't happen, and it doesn't mean other people haven't seen that. Where I see it more often is when we drain the peritoneum. Like, for example, someone with ascites who's got a really big abdomen. Draining that too quickly, too much too quickly, can definitely see effects on the blood pressure. Someone with pleural edema, same idea. The pleura can hold liters of fluid, believe it or not. So now let's just talk generally, in principle, of draining any of these cavities too quickly. Any of these cavities drained too quickly can cause a problem. So let's say this is a cavity here. Let's just say this is the pleura, for example. The pleura is surrounded by blood vessels all over the place. And let's say the pleura is super enlarged with fluid that's not supposed to be there. What's happening? That fluid, that pleural lining now is pushing up against vessels, putting pressure against vessels. Circulation flowing through the vessels is pushing up against that pressure too. If this pressure decreases suddenly, this is able to flow through. Or you could look at it, this is able to expand and thereby lower pressure. Either way you look at it, you get a rebound drop in blood pressure. It might be transient. The drop in blood pressure might not last very long because the body will readapt. However, depending on how old and compromised the patient is, it might not rebound that quickly. And even if it's a transient drop in blood pressure, you could still have the risk of falls, lightheadedness, etc., etc. So you want to be careful whenever you're being asked to drain either the abdomen, the pleura, not so much the bladder, but throw it in there for good measure, maybe the bladder. Usually when we drain the bladder, we just let it drain. But when it comes to pleura and ascites in the abdomen, if a lot is draining really quickly, you may want to get some guidance from the physician about how much they want you to drain right now before putting a stop on the drainage, giving a break to it. You can turn these drains off and on. Again, a catheter is not really, but the abdo drains and the chest tubes, you can take breaks from them. It's possible. We'll talk a little bit more about that in I&P. Okay, so let's go back to the questions now. So in map 4, you've just got a little pictorial down here explaining what I just said. Too much fluid removed too quickly, a rapid decrease in pressure against surrounding vessels. Fluid can shift out of vessels into lungs, into the pulmonary area, a drop in blood pressure, etc., etc. Which brings us back to the question we were looking at earlier with Rick here. So what happened to him when we took 2,000 out and didn't, clamp anything off here, didn't give him a break? Well, he does seem to be breathing easier because we've taken fluid off the lungs out of the pleura, allowing the lungs to expand. But now his blood pressure's dropped, and here's why, which we've already talked about. All right, so we go to question number 6. Why is right-sided heart failure a potential with PE? The better way to ask that question is, why might we expect right-sided heart failure first? Because eventually we could get left-sided failure too, when the whole heart fails. But why right-sided failure? Look, the easy answer is, where's the right side pumping blood into the pulmonary vessels? If you've got an occlusion in the major artery in the pulmonary vessels, it's causing blood to back up, and the heart has to push against it. The heart can get tired and fail. That's basically what's summed up right here. And for people who like the mapped version of things, you've got it right here. You get a clot. This is talking about how do you get the clot. You know it can come from the heart, it can come from the legs. It ends up in the pulmonary artery, and you've got all this pressure that the heart has to push against that could cause failure. You are responsible for these maps. This atelectasis is a good one. A good review on how the mucus plugs. Obviously, if there's a mucus plugged up, blocking the flow to the alveoli, then the alveoli is not going to be able to pick up any new oxygen, for example, and it just empties out into the bloodstream and collapses. This is atelectasis. This is why you want people to deep breathing and coughing. And there's a nice picture of this actually in the PowerPoint right here. You can see things are working fine. Then the mucus builds up, it gets plugged. Whatever was there moves into the bloodstream, nothing's more is coming in, they just collapse. Deep breathing and coughing. This is movement, mobility. This is the way to avoid these problems. And just the next map, getting back to pulmonary embolism, head to toe guy here. I mean, a lot of it should be reviewed, and if not, it should be very intuitive based on what a pulmonary embolism is, how it affects each system, what we hear. Just a couple points maybe to highlight. Don't worry about friction rub. There's something about friction rub here. We're not doing it. We're not going to be listening for that. So don't worry about that one. The rest here we've talked about or is very straightforward. I want to remind you that usually heparin IV is the treatment of choice to help that clot, the body break that clot down. We're monitoring PTT. Heparin IV is out of your scope, but you may be looking after patients with an RN who have that. So fluid resuscitation if shock. Okay, and then these diagnostics we're going to talk about in a minute in the next question. So let's not worry about that right now. Okay, so question 9 we already talked about. What is the difference between these two? Which of these two would you expect to cause an increase in heart rate? Well, hypoxemia usually precedes hypoxia. Hypoxia is the one that gives you the symptoms. Okay, on to question 10. Explain how a VQ scan works. We'll look at a handout on Moodle to talk about that one. How does the D-dimer work? We can look at something for that too. Just note, this is for diagnosing. A D-dimer is to tell you if there's a clot in the body at all. So if a D-dimer is elevated, it tells you that there's a clot somewhere in the body because the body's trying to break down the clot. You get this degradation product or debris from the clot. That's what the D-dimer is picking up. So there's a clot somewhere in the body, we don't know where. You need more diagnostics. If you get a negative D dimer, then you know there's no excessive clotting in the body. You don't have a PE. You don't have a DVT. So that's how that test is useful. A CT, a spiral CT, is a very common way now that they use to find out if someone's got a PE or not. And if for some reason they can't get the CT, like they can't take the dye or something, then they go for a VQ scan. And we'll just talk about a VQ scan here before we wrap up this video. So this is a really, really useful document on your Moodle shell. It's not maybe the most up-to-date, I'm not gonna lie, I haven't updated it, but it doesn't need to be because it's talking very generally about what these different tests do. And so you can read up on the VQ scan. Basically what they're trying to do is match up where the perfusion's going, or not going in the case of a PE, to where air is being breathed in, how much they're able to breathe in. Because ultimately you want the air you breathe in, the oxygen, to meet up with blood flow so they can be that diffusion of gas. So that's what the VQ scan checks out. So here's someone going for a VQ scan. You can see it's a pretty intense procedure, pretty costly. If you can diagnose the PE with a spiral CT, it's probably preferable.